Okay, let's begin. We're talking about a heart under pressure, a life that's hanging on by a thread.
Time is everything here. What you're about to hear is a 28-second blitz on how to spot a killer. Make no mistake, cardiac tamponade is a surgical emergency. It's the pressure that kills.
First, the hallmark signs. You're looking for Beck's Triad: hypotension, muffled heart sounds, and jugular venous distension. Then, check for Pulsus Paradoksus. That's a systolic blood pressure drop of more than 10 when they breathe in. And on the EKG, you're looking for Electrical Alternans. The heart is literally swinging around in a sack of fluid.
Now listen closely. Forget the usual meds. Giving diuretics or nitrates here is a death sentence. You'll tank the preload and the heart will just stop. Your only first move, is intravenous fluids. That's your bridge to get them to pericardiocentesis. So remember, know the triad, find the swing, and drain the sac.
Let's go!
And now, we need to pause. Before we go any further, we have to cover a critical safety protocol. This is our mandatory international medical disclaimer.
This content is for educational purposes for international boards only. It is not medical advice. Always consult official guidelines and a specialist physician for clinical decisions.
Okay, now we can get into the real physics of this, the why behind the what. Sarah, in our last session, we were dealing with the fire of inflammation. Today, it's a flood. The pericardial sac is literally overflowing with fluid.
So let's start right there with the most terrifying part of this, the right ventricle actually collapsing during diastole when it's supposed to be filling. Why on earth does that happen?
Well, Dr. Collins, it's really just a battle of pressures.
Think about trying to inflate a balloon inside a sealed, rigid jar. You can blow and blow, but eventually the air pressure inside that jar is going to push back so hard the balloon just can't expand anymore. That's exactly what's happening to the right ventricle. The pressure from the fluid in the pericardial sac gets higher than the filling pressure inside the right heart, so it just gets crushed flat. And since the right heart is the low-pressure side of the system, it's the first to give way. The result? A catastrophic drop in cardiac output, and that's the hypotension we see in Beck's Triad.
Exactly. Perfectly explained. Now, let's get to another one that trips people up all the time, Pulsus Paradoksus. So, why does something as simple as taking a deep breath cause a patient's blood pressure to plummet?
Right. This comes down to something called ventricular interdependence. The easiest way to think about it is to picture the heart as a house with two rooms, a right room and a left room, and they share a wall. When you take a deep breath in, a whole bunch of blood rushes into the right room. But remember, the entire house is trapped in that fluid-filled sac. It can't expand outwards. So the only way for the right room to make space for all that new blood is to bulge the shared wall into the left room. This physically makes the left room smaller, which means it can't pump out as much blood. And that's it. That's the drop in systolic pressure of more than 10. It isn't some kind of magic. It's just a simple physics problem, a space issue.
That is a fantastic analogy. And you know, for everyone watching who wants to go even deeper on this, we've put a link to the 2015 ESC guidelines in the description. They have an incredible section on what they call death traps in tamponade management. And speaking of death traps, Sarah, what is the one drug you absolutely never ever give to these patients?
Diuretics and nitrates. Giving either one is a catastrophic error. You have to understand, these patients are completely and totally preload dependent. They need every single drop of blood volume they have just to generate enough pressure to fight against that external squeeze. The moment you give a diuretic or a nitrate, you destroy their preload, the whole system collapses, and the heart stops. It is that simple. So for your boards, but much more importantly, for your actual patients, if you even suspect tamponade in a hypotensive patient, the first thing you do is hang IV fluids while you get ready for that pericardiocentesis.
That's such a crucial point. Fluids are the lifeline. They literally prop the gate open. Okay, let's look at that EKG finding.
Right. Electrical Alternans. It's exactly what it sounds like. The heart is no longer fixed in place. It's literally swinging back and forth in all that fluid. So with every beat, the electrical axis of the QRS complex changes. On the EKG, it looks like the complexes are getting bigger, then smaller, then bigger again.
All right, it's time to burn this into our memory. Sarah, are you ready? Let's chant the lethal pressure. Beck is the triad.
Dr. Collins and Sarah, paradox is the drop.
Alternans is the swing, ECG.
Fluids are the bridge.
Needle is the fix. No diuretics, in the sack. Links? Review.
Fantastic. Now let's get to our question of the day. We've all seen them, those patients walking around with chronic effusions, the ones we call the slow accumulators. The question is, have you ever seen one of those cases suddenly tip over and decompensate into a full-blown acute tamponade? Tell us your stories, share what you learned, right there in the comments below.
The pressure is locked in. Just remember, Beck, Paradox, fluids, and definitely go review those links. Excellent work. So today, we figured out how to save a heart from a prison made of fluid. But what happens when that prison turns to stone? You'll have to join us for our next module, where we are going to tackle constrictive pericarditis, what I call the concrete cage. Make sure you subscribe so you do not miss it.